Good morning and good afternoon, and welcome to this third session of our seminar series, Why Behavioral Interventions Work or Don't Work. My name is Theo Sandvoort and I'm the director of the HIV Center's Development Core, and this seminar series is organized in collaboration with the Science of Behavior Change program here at the Columbia University Irving Medical Center. And I would like to thank my colleagues Brian Kuttner, Talia Cornelius and Jeffrey Burke for organizing this seminar series together. In our first session, we were introduced to the behavior change wheel with 7 policy categories to support the delivery of 9 intervention functions. And we also learned about the very impressive taxonomy of behavior change techniques. That was a very theoretical session. In the second session, we became more practical and we learned about research methods focused on the study of behavior change mechanisms and how to incorporate these mechanisms into one's own research. Both sessions were recorded and they can be accessed online, as this session will be. And here are important links that you might want to take a look at. They will be in the recording of this session. The first link is the place where you can find the recordings of this seminar series. The second link is the link to the behavior change wheel and the human behavior change project, and that's also where you can learn about the taxonomy of behavior change mechanisms. The third website is the website of the Science of Behavior Change program. And if you go there, you also can find several tools that you can work with to learn how to integrate mechanisms into your study design. So this slide will be in the recording if you want to access that later. This seminar series has been so successful that we are planning a more hands-on follow-up. And the first one is planned for January 31st, and participation in these sessions will be limited on a first-come, first-served basis. In today's session, we will learn about the application of a mechanistic approach in completed and ongoing behavioral HIV studies. And it's my great pleasure to introduce to you my colleague and friend, Dr. Kathleen Sikkema. Dr. Sikkema is a clinical psychologist who is specialized in health and community psychology. She is the Stephen Smith Professor and Chair of the Department of Sociomedical Sciences at the Mailman School of Public Health here at Columbia University. Funded by NIH for over 30 years, her domestic and international research program has focused on community-level HIV prevention trials, mental health interventions to improve HIV care engagement, and university-community research collaborations. What she will describe today is the arc of her behavioral intervention research, from her very first outcome-focused studies leading to a deliberate approach to study mechanisms of action. After her presentation, Dr. Sikkema will be joined by Dr. Talia Cornelius of the Science of Behavior Change program to discuss core questions about designs for mechanistic studies, as discussed in the second session of this seminar series. The title of Dr. Sikkema's talk is If Interventions Work, Why? Elucidating Mechanisms of Behavior Change through Evolving HIV Mental Health Intervention Trial Designs. If you have comments or questions, you can put them in the Q&A. We are monitoring what's coming in, and we will try to integrate your questions and comments as much as possible at the right moment during this session. Kathy, the floor is yours.
Thank you very much, Theo. Please let me know if this is as we would like to see it. Showing okay on screens?
Yes.
Very good. Okay, thank you. Greetings, everyone. It's a real pleasure and exciting to be part of this seminar series, and I have observed the previous two, and I'm glad to have the opportunity to share with you ways that I have thought about mechanisms of change over time, how, as Teo said, we are targeting that much more in our planning of intervention trials now, and thought that I would try to provide, with most of the emphasis on the current research, but give a sense of, if I can do 30 years in just over 30 minutes, I will obviously just hit some highlights, but to give a sense of how things have changed, how designs and interventions have been developed over time that will help us elucidate these mechanisms. So just for a frame of reference, these are some of the points I want to make as I go through the examples. And in both development and design of intervention trials in order to hopefully better identify causal mechanisms. I am certainly not the only one that does this. I just want to show as an example how we have done this over time. And I imagine that people are at various stages of their career and their experiences with intervention trials. So hopefully this will be helpful in thinking and planning for the future, looking at our progress, setting our goals for how we advance this agenda further. So the first point that I think will be clear is how our research questions change over time. Of course, that happens in all areas of research as we learn and theories develop, that those questions change. I think this is especially true in HIV treatment and prevention research, given the types of progress that we have seen, and that will be reflected in the examples I will be providing. It seemed quite odd to actually put as a bullet point, well, you must begin with theory. I think we think about theory, and I think most of us think about theory, and the extent to which we apply it to what we measure and what we test and how we set up a hypothesis are things I would encourage you to think about. This, of course, is related to the trial design. What type of experimental design does one set up? What is the control or comparison condition? How does that design provide stronger support for examining our theoretical mechanisms and causal mechanisms of change? Very importantly, how we measure it. We need to have the strongest measures possible that would support looking at causal mechanisms and outcomes, and thinking about when those assessment points are actually conducted, when we do which assessments to help strengthen the conclusions we might draw about mediating mechanisms. And the final point is the significance of ethical issues in trial design. Whether or not this is directly related to causal mechanisms, I'm not certain, but I always think it's important to emphasize, as one is deciding on a control condition or elements of an experimental intervention condition, how do ethics come into play? So this is the mindset that I think would be helpful if you would take as you see some examples of mine, and that we'll come back to then at the end, hopefully for discussion. As Teo implied, I have done community-based intervention trials for over 30 years, and most of what I will talk about today are the mental health intervention trials, but I just want to make a point about community trials that I think we have probably even thought less about mechanisms of change. And so this was, I think of my career at this point in 3 decades, the first decade when we did not have treatment and we were heavily focused on prevention in a very primary prevention way. The second decade where treatment was available and we focused much more on adherence and places that had access to treatment and places that did not. And then this last decade that I think of with increasing access to treatment, including PrEP and other biomedical interventions for prevention. So in that progression, that's in my mind the way I think about where we've been in the epidemic and how that affects our priorities. So I just wanted to use this series of community level trials that I did when I was first a faculty member joining Jeff Kelly's group, where I actually, my first responsibility was to direct the gay bars in small cities study, which was really thinking about it only 5, 6, 7 years into our doing behavioral intervention prevention research, moving toward beyond the individual level to community level trials, and thus moving to the theory of diffusion of innovation, really going into a different domain of theory, which we then we took what we learned from that effective intervention, what we learned from it, which was really about changing norms through conversation, to women in low-income housing developments. Also, that was 18 housing developments around the United States, very quickly learning that the social context was quite different for this population, needed a different intervention approach, and really moved to integrate much more cognitive behavioral skills training oriented work to enable conversations and change norms to settings where these types of topics were talked about in the context of other stressors, which is certainly still the case today in work that we do. And then lastly, I will talk about as an example of moving towards really a multi-component intervention. What did we know was state of the science? This was about the mid to late 1990s, where skills training was becoming quite evident as effective in behavior change, reducing sexual risk behavior and substance use, and particularly among adolescents. And so the question for this study, based on the prior two, was could a community level intervention add to what we felt state of the science was showing us for adolescents in a community setting. So this study design, and I just point this out quickly because I think it helps us get in the mindset of what are we comparing? How do we decide what we're comparing to? So if you think of skills as state of the science, this was actually a comparison condition compared to education only. And then the question was, if you added a community component of mobilization and norm change and peer leadership to skills, what was added to that? So without going into a lot of detail, but just for thinking about those of you doing community level trials, how you set them up and what you might look at in terms of mediating mechanisms. These were young people like 11 to 17 years old. So one outcome was for those who had not yet had intercourse, how many initiated, what was the sexual debut difference? And we were able to show at the long-term follow-up that those that received the community condition were actually more likely to delay first intercourse. In contrast, or maybe in parallel in a different way, the sexually active adolescents had the greatest effect, if you look here, from the skill. There's no difference between the skills and community, and the greatest effect was from skills training. So in some ways, it's much more of a component analysis, but I just wanted to show a representation of something earlier on that gave us a sense of how to think about what we're looking at, picking apart interventions, and what maybe if we were to do a mediating analysis in that type of study, what we might need to take in mind. So the primary focus of what I'm going to talk about is the study I'm doing currently, which we're literally right in the middle of, on sexual trauma and HIV with viral suppression as the primary outcome. So this is, I think, an excellent example of the focus of our research. Even as mental health researchers, we certainly want to show improvements in mental health. But given its the current state of our research, we also are asking in many mental health intervention, in some mental health intervention trials, can mental health have an impact on adherence? Can it have an impact such that we can see clinical outcomes like viral suppression? So I'm doing this study with my longtime colleague and friend, John Joska at the University of Cape Town. So I'll talk more about this study. The thinking of it essentially is what I was just mentioning. If we think about a goal, even for mental health interventions, as viral suppression, first of all, is mental health a good focus for that? And in my own work, why focus on trauma and sexual violence? And I'll get to that and its theoretical and conceptual foundation. But guided by the points below, what studies have been done? What are needed? Do we know what works? And if we know what works, why? And what does that tell us about how to implement? How to certainly be thinking about the hybrid effectiveness implementation models, how we can be much more likely to get this to scale if shown to be effective. So just a couple of points on how one starts to think about forming why do these interventions and what they may focus on. So I think over the last decade, there is certainly descriptive research that shows that various mental health and ill mental health is related to poor retention and care and poor HIV medication adherence, and a couple of areas that have been shown to be not necessarily in a causal mechanism, but associated with are areas of shame and stigma and avoidance. You will see that those are psychological consequences of sexual trauma. This is part of why I focus on sexual trauma. But what we're trying to do is there are ongoing and a couple of completed mental health intervention trials focusing on depression, looking at viral load suppression. But, and there are studies going on with interpersonal violence and other trauma interventions, but we're trying to show in this case that if we reduce traumatic stress, can we increase care engagement and then increase viral load suppression? So I'm going to give you the overview first of the study design, then give some background on how we got to the study design and progression of studies there. So it is an effectiveness implementation design, individual intervention that's clinic-based, that the experimental intervention is called Impact Plus. I'll come more to that, compared to a control, but really a comparison intervention that is considered likely to be effective as the control condition for women as they initiate ART, because this is really a window of opportunity as we see it. If you think about window of opportunity literature, sometimes pregnancy is seen as a great time for that. It really developed out of emergency room for accidents related to alcohol, lots of relevance to the window of opportunity idea. And then there's these two types of really maintenance follow-up periods for adherence, but the study goes, the intensity of the intervention is in the first section and then followed for a year. And it's this year point where we're looking for viral load suppression. And we also take, through our own samples, we do dried blood spots for adherence. I'll come more to the measurement in a few minutes, but that's the overview of the current study. So I'm going to do a quick look back at how we got to this, and hopefully that's helpful in thinking. So in fact, I'm sorry, let me say a little more about then what that means for the conceptual model and how this is really what we have set up intentionally to hopefully be able to look at mediating mechanisms of mental health improvements. So this is the Impact Plus is the experimental intervention. The primary outcome is viral suppression and ART adherence through the biomarkers, as well as medical records and retention and care are the secondary outcomes. The question is, if we are able to show an effect on the clinical outcomes, are we able to then show that those are due to a reduction in avoidant coping, and separately and reductions in traumatic stress. So essentially the idea, can mental health improvements result in viral load suppression? That's the conceptual model. So how does one come to this? And this I'll try to do briefly and hopefully not get lost in details, but I have done a few studies that are based on the on stress appraisal and coping, cognitive theory of stress and coping. And this really started in the mid-90s when my first mental health trial was on AIDS-related bereavement. And I'll tell you about that design in a moment. But I selected this model partly because Susan Folkman was doing work in AIDS bereavement at the time, and clinically and conceptually, because the stressors were living with HIV and having lost loved one or loved ones to HIV, that it seemed that there was this sense of broad stressors that could be specified, determined as changeable or not, and then have a very specific emotion focus or problem focused coping strategy, and then use this model. This particular decision tree was put together by Folkman and Chesney, as they also related this, this theory to stress management in general among people with HIV. So the study design for the bereavement intervention, which was intentionally focused on mental health, not on risk behaviors or clinical outcomes. This was done, I think, started in 1995. You will see what would be, I think, a typical study design where we were doing this intervention in a group. And so it was a sort of what I'd say now is a traditional Western model of mental health, 12 sessions, I think, lengthy group intervention compared to individual therapy upon request, which was decided after much gathering of information about what was the standard of care at the time for AIDS bereavement and grief, and that was essentially what existed. So without going into a lot of details, we were able to show a reduction in traumatic grief and overall psychiatric distress. And we actually did go back and begin to take a peek at mediating mechanisms. It was theoretically grounded in how the trial was set up, but we then said, well, let's see what coping did in this. And we were able to show that reductions in avoidant coping did mediate these reductions in grief. But it was really sort of a look back in many ways. So the next study, which was really what is most directly related to the current study that is more set up to look at mediation, but we did also look in this first sexual trauma study, which was done in the United States. Coming out of the bereavement study, it was really traumatic grief people were experiencing, and much of the interventions were focused on trauma overall. Again, context to time, this is the late 90s. We're seeing much more data on the association between sexual trauma and HIV risk, joining forces with people that had worked in sexual trauma for their careers, that this was honestly not a surprise, but began to be a focus of what we did. So similar to the bereavement study, I didn't make a study design slide of the first trauma study, but the biggest weakness, of course, in this that I think is pretty obvious is that we don't really know what the group effect was here. So what we did in the trauma study was to compare a coping group to an interpersonal support group. So it was time matched, led by professionals, much more set up to, I think, to build the case for the coping effect. So, and what we were interested at the time, because of what we knew about the impact of sexual trauma on substance use and sexual behaviors, we were looking at whether this mental health intervention could affect sexual behavior. In this slide, the darker blue are the coping group compared to the support group. So if you look at the trajectory, you see a significant decrease in sexual risk behavior, vaginal or anal, positive or negative partners, as well as reductions in alcohol use, cocaine use, and then looking at the mental health effects. This is where we began to think much more seriously about mediation. So essentially, what this growth model, SEM model, shows is that the intervention, so the coping group compared to the support group condition, the coping group significantly reduced their traumatic stress, symptoms of PTSD, as well as had more decreases in avoidant coping than those in the support group. And when we did this model, you can see that the reductions in avoidant coping nearly fully mediate the reductions in traumatic stress. So it was our feeling like it was a strong step towards supporting this coping model that we were using. And these outcomes together resulted in LIFT as a best evidence for CDC and for SAMHSA. So that led me, and this is where it becomes a little bit closer linked to what we're doing now. That led me to think about, and many of us to think about, how does mental health work? How does the impact of a mental health intervention, if it is effective in terms of substance use and coping and other mental health factors? Again, this model we developed almost 15 years ago now. So this was when we started being much more confident and focusing on improving adherence through effective interventions to try to get to viral load suppression, and thinking about population level transmission, how reducing the viral load might reduce HIV transmission. So my first thinking about this was actually, how does this model work for prevention, but knowing that viral load suppression was in here. So we as well. So you see there are a number of factors that conceptually could be related, but this was when we started thinking about the great potential multiple impacts of improving mental health. Of course, we know that HIV exists in a syndemic context. And so thinking about, while these are individual level interventions, how do we develop and do interventions in settings where we can also consider the syndemic context? So this is eventually what led to, this was a pilot trial, R34, also done with John Joska at UCT, building on the US work and other South African work. Could we, in the context of co-occurring epidemics of sexual trauma and HIV, knowing that sexual trauma relates to poor health outcomes, could we address traumatic stress in a way that improved sexual trauma symptoms and mental health overall, as well as improving care engagement? And that, in also thinking from a global mental health perspective, that given that the limited availability of mental health providers, LIFT, for example, was delivered by people with masters in social work, trained professionals with training in therapy. And so how do we adapt this intervention? How do we adapt, or how do we redevelop, just using the same concepts and intervention that could address these issues, but have it be possible to be delivered by non-specialists so that it could potentially be implemented and sustainable? So just briefly, this is up in my mind, was a very interesting process in and of itself. These may not look to you like the theories and the conceptual foundations that they represent. This is actually the coping model. One thing we learned very quickly in our formative work was that LIFT and many of our evidence-based trauma treatments are heavily cognitive. And we, even my colleagues at the university responded that it was a highly cognitive way of thinking, not as affective, not as relational and interpersonal. So we worked very hard to take these evidence-based components. And essentially what we do now, instead of showing a decision tree, is we land a big bag of pebbles and rocks on the table to represent global stressors. They're painted orange and purple so that we move towards changeable and unchangeable, and people literally in a interactive, tactile way use the coping model that goes throughout the intervention. Head, heart, and hands we do like this, means activity and behavior and relationships. And then this is a key component from cognitive processing therapy: power, self-esteem, trust, and safety, represented by the Mbisa pot, the Mbisa model, which is a community cooking pot that we use because it's very well known that it's a three-legged pot, and if you don't have one of those three legs, it won't stand up. So it's very symbolic, interactive, but is really based on theoretical foundations. Without going into a lot of detail on this, but to make an important point, we developed this intervention as a 4-individual and 3-group session intervention. Pilot tested that through the R34. At the time, this was pre-test and treat. At the time, there were 3 required sessions of adherence counseling in clinics in South Africa before you could get ART. So we used that as our control condition, and then added this other, the experimental intervention. We found reductions in, we found improvements in coping, reductions in traumatic stress and depression, primarily at the 3-month point, remained but diminished by 6 months. And so we actually think, it's another topic, but we had very poor group attendance in this intervention, which was not the case in the US LIFT study. So we took, this is why one does pilot trials, we took all of this information and then modified to what I will show you is the trial where the intervention we're testing at this point. We did do med record reviews and we took our own dried blood spots and med record reviews And in addition to the mental health potential outcomes, we're able on a majority of the participants, again, it was a small sample to start with, 60 people in a pilot, but we were able to show that participants in the impact study did demonstrate potential for clinical outcomes by adherence markers in dried blood spot or viral suppression taken from medical records. So all these things together led us to the study that I was mentioning that we're doing now. So just to quickly review, because I hope that the talking about the sequence of studies gives you a feel for, one doesn't just say, wake up one morning and say, let's do this study design. A lot of it obviously comes from the literature and other research that's available, but I think the sequence of the starting bereavement and the trauma studies in the US and the really incredible value of the pilot study that we did in Cape Town that led to this helped really refine an intervention that we hopefully will be effective. So what happens, and I'll give you a little bit more detail, but all women who are initiating ART are referred to us. And so I'll talk to you more about, in some ways, there are clinic level factors in this type of intervention. And they're randomized to the Impact Plus or the problem solving therapy, baselines before, and then assessed every 4 months for a year, with self-report mental health and some behavioral measures as well. And then the blood is taken at each spot to do at each assessment point to take dried blood spots and do the viral load testing. So just a little bit about the study. So hopefully you can sort of think about what it's like to do these trials in a very applied, often challenging setting. Add in there, 9-month delay due to COVID. I mean, as we know, these are challenging trials to do. So I think that cannot go unnoted, given the how complex it is to do these and to set these up in a way that we can potentially have the best optimal designs to find, if an intervention works, find out why. So this particular study is done in 4 clinics in the Western Cape and Kailicha outside of Cape Town. So I alluded to how this process happens. Essentially, for multiple reasons, we don't want to bias who's referred to us. We don't want to bias someone knowing what the study is about, because we have the inclusion criteria includes, of course, having a history of sexual abuse or assault, and it is not an intervention that's focused on people with particular diagnoses. They have to at least have some symptoms that reflect PTSD, and most have many, but it's not intended for an outcome to go, as from a mental disorder to not having one. It's more along, if you think about LIFT and the logic behind it, is that having experienced trauma, living in a context of complex trauma and many other traumas, how does one potentially reduce avoidance that comes from all of that? So it's very related to varying levels of trauma, can go up and down. And so we're much more focused on having the traumatic experiences, but they're referred to us. We do a screening for eligibility on these factors. We confirm in the medical record, and then they come back for a baseline assessment, and they are randomized after the baseline assessment. Happy to talk more if necessary about the details of how that's done, but I think the broader focus here is that we're comparing these 2 interventions. And I guess just to come back a moment to the comments about why it was so important in the LIFT study to compare a coping group to a interpersonal support group, was to help us refine whether the difference was related to the real coping content in the intervention. So this intervention we ended up with is 6 sessions in between the 0 and 4 month assessment point, and then essentially brief booster maintenance sessions that are linked to pill pickups or other clinic visits delivered by a non-specialist, but the focus really is integrating coping with trauma, and HIV treatment comes into play in there. I'll say more in a moment. Compared to problem-solving therapy, brief problem-solving therapy, which is essentially endorsed by MHGAP, the WHO. We know that it's something that is being potentially delivered in more and more communities around the world. And what we wanted to be able to also delivered by lay counselor, non-specialists. We also wanted, this is the real ethical point here, that there's very little screening of mental health concerns, let alone asking people in a systematic way if they've experienced sexual trauma. So it seemed completely unethical to screen for sexual trauma and then offer someone standard of care or referral, and that we felt they had to also receive an intervention. So we're actually setting the bar quite high to show an effect. We're comparing 2 interventions, but could not come to a place where we felt even some of the time matched but not content matched potential topics for intervention. We went with something that could potentially help from a stress management perspective. So this is just a visual of the topics of the 6 sessions of the intervention that we're doing, and you can see that it begins with trauma, sexual trauma, and HIV, moves into the coping model, how coping can be related to HIV care, and then really directly linked to coping strategies as it relates to adherence. The problem-solving intervention is adapted, as I said, from Problem Management Plus, something honestly we expect to see improvements in mental health, certainly at 4 months and potentially maintained. The most common, the way this works is the woman identifies the thing that's bothering her the most right now. And then and most of the time it's unemployment or it's family. So it's things that matter, and they learn some basic stress management skills. So those are the 2 interventions that are being compared. This reflects our outcome measures, just to restate again that we are looking at viral load suppression as the primary outcome and ART adherence as the secondary outcome. And the two hypothesized mechanisms of action are reductions in traumatic stress and specifically improvements in coping, which has been typically shown to be reductions in avoidant coping and improvements in active coping. That said, I will say, as many, if those of you who do coping research know, there are a handful of measures. They quite vary. Some are used more than others, some are longer than others. And so we have essentially, over the 20 years of doing coping research, developed and adapted a coping measure for the South African context that we feel quite confident about. That's a combination of various measures. And in the area of coping, one should always do a factor analysis with their sample to determine what the subscales are anyway. So it could be that there will be some other factor that comes in this population that may prove to be even a more significant mediator than avoidant coping. But that is our focus in looking for the mediation. We just published the protocol paper in Trials, if anyone's interested in the actual more details on the study. But just to reiterate, as I come to a close, I think I'm going to make it in 35 minutes, Teo, that this is the conceptual model that we developed as we thought about the work that we had done across these studies over time. And this is what we hope to test, hoping that we see effective outcomes in the clinic, biomarkers and clinical outcomes. So just to set us up for, and maybe you've already written questions, but for questions and discussion, coming back to the guiding principles of, at least as I was thinking about them for this focus on mechanisms of change, when one thinks about developing an intervention and even what the theory and the content would be most appropriate to be, and how to design the trials, acknowledging that research questions change over time. So what obviously might have been done 20 years ago is not necessarily the proper design or an area of focus for an intervention. Thinking about where we are in terms of really making great progress in so many ways in HIV treatment and prevention. I think about the beginning with theory. I would be curious about perception of the way I presented theory here. I think in the mental health trials, at least the ones that I'm sharing with you today, the coping theory really is clear throughout them. I wanted to start with the community studies just to show how we really found by varying population and what we were learning that we combined theories or moved theories. And I mean, I would hope that this type of research would advance theories and potentially development of new theories or integration of theories depending on a multi-component nature of an intervention. Like I would just put those types of topics out there as ways to think about theoretical contributions to the field. What the experimental intervention is, what is the control condition? Ideally, we would all love a 4-condition study. Those are sometimes quite difficult and expensive to do. The extreme importance of the measures that are selected, and what I didn't emphasize is that, you know, of course, that's not the right slide, but the what I do want to say is that it's important that we're measuring the mediators before the outcome. I mean, I sort of implied that with the study design, but let me be real obvious about that. So the assessment time points, measures used, and how ethics are considered in making, ethical issues are considered in making these decisions. So I will leave it there and just acknowledge over the many years, this is really the combination of LIFT and impact teams over the years. And how what we all learned together is related to this current study now. This is our investigative team at Columbia and at UCT. And let me just comment, I haven't really said too much, but it's this is intense work. I just want to say we're focusing on mediating mechanisms, but the day-to-day of running studies on mental health in contexts that are highly potentially traumatic and assessing and talking about sexual trauma on a daily basis is a very intense experience. And we've done a lot of things related to debriefing and supervision of the team, which is really a different topic, but important to note. And of course, this is the field team and the investigative team at Cape Town. So I want to acknowledge them by picture, not just name. So thank you, Teo. How's that?
That was terrific, Kathy. Very well organized and very clear, and really drives home the arc of your career and where you started in intervention research and how your thinking about mechanisms has advanced as the field has also advanced, and a really fine model for how to build a body of research over time. We have a couple of questions, and one of them is, it's on that last point about ethics. And I know you had said you put that on wondering if people would be so interested in it, but it has stimulated a question.
Sure.
When designing mechanism tests, you have to be very rigorous about content and also very specific about hypothesized pathways. In some cases, withholding certain evidence-based treatments or controls makes for a better test, but it's clearly unethical. How do you balance these potentially competing scientific versus ethical considerations? And this question, to be clear, comes from Talia, so she posed it to me in the chat.
Thanks, Talia. What would I say? I hate to, I'm going to use the word values. I mean, I think that it's interesting what came to mind. I'm going to give an example and then talk about why I think this is so essential. And I think the values statement is that it's all driven by showing an intervention works that has a chance of actually being used, right? And so that's why I made the comment on implementation. I think this is just a comment from someone who's always done applied intervention work in the field. But for the sake of efficacy, would have probably shown things to be effective with half the sample size and less the complexity if I had not thought about what is an intervention that could work, but could be implemented by people that are in the communities that could deliver it. So accessibility, sustainability, all of those questions really guide the way I think about taking those things into account. The example I was going to give is in the bereavement study, the reviewers of the grant strongly suggested that I exclude anyone with a major, with a psychiatric diagnosis, essentially. People that use substance use, that were substance use diagnoses, that had personality diagnoses. And I didn't do that. We did a skid on everybody and we stratified by psychiatric diagnosis. And what I always say is that that's when we were, if you guys remember, we were talking about being triply diagnosed, dually diagnosed, triply diagnosed. So I think something like 70% had 70% of people in the sample had 2 or more diagnoses. So the whole notion was, of course, it would have been easier to run a group intervention without complexities of psychiatric influences, but then it wouldn't have been valuable to anybody that was seeking the service. So that's, I guess, what I'm saying guides the way I think about it. And so we were also, I mean, I do think it's a real balancing act. Like, does one think they can set up a study design to potentially elucidate the mechanisms, but still be testing an intervention that will not just sit in a journal and that is at the level of being able to be used? So
that's a very useful answer. It's about the potential impact, not just on the findings of your research, but actually impact in the field in which you're actually hoping to implement.
Well, and just one other comment on that. The other thing that I think we often don't think about is, as much as we should, is not just the intervention delivered, but I remember thinking in the 90s, who's going to assess everybody that comes into a community organization to determine what their psychiatric diagnosis is, to then tell them that this intervention was never used with people like you. So, I mean, the steps that we do in research to keep it as potentially clean as possible often highly contradict what happened. And that's partly why we're using the ART initiation clinic. We hope that this intervention, if it's effective, can essentially be delivered to anyone that comes in to start ART that has a traumatic experience.
I've got another question. Some of the questions, I encourage you to pose questions in the Q&A so everyone can do that. Some of the questions that have been posed are really, I think, be addressed once Dr. Cornelius and Dr. Sikkema come together to discuss. So there is another one I can think of now that might be more specific to the content of your work, Kathy. And this one comes from Teo, to be clear also. What would you say if you find no support for the mechanisms? Would you have alternative explanations? Would you conclude that these mechanisms are not relevant? Or could you imagine that there are too many factors negatively affecting the internal validity of the study? This is in the case of the R01 that you're conducting now.
That's a lot of questions in one, Teo. So let me think about picking them apart and then come back at me, Brian, if I missed a couple key points.
Sure.
I mean, I think, okay, so if we get biomarker outcomes and not mediation effects, that it was through any change in mental health. Let me think. I mean, the first thing that crosses my mind is that we're comparing 2 mental health treatments. I'm trying to think like if somehow they both improve mental health, but there was something about what was in the experimental one that resulted in viral load suppression, right? Like I'm trying to think, like we're thinking of differentiation of those points really, which is we might see a change in biomarkers and clinical outcomes, but we don't show mediation of mental health. It could be that there was an effect from both conditions, right? I mean, I'm trying to think about how that's related to the internal validity also. And of course, I'm trying to think like, are there other outside factors that could have resulted in the viral load suppression? And this is why I believe in doing RCTs, to tell you the truth, like hopefully, and they're balanced in the clinics, and hopefully there isn't, you might speculate that there might be something different in one clinic, or there might be, there's something about the delivery of care or access to ARTs or other factors that really aren't mental health related. But hopefully the randomization within clinic and blocking for various things, that might affect that would take that, it would help to be more certain of that. I mean, I think at least what's coming to mind is that there'd have to be there's got to be a causal mechanism. We just didn't measure the right one, right? I mean, I think that's what I would say. I mean, what's making that happen? I mean, I was thinking, well, it could be because you're in a study, but that wouldn't be the answer either. It's always why I wish I had a third condition. You know, I think we always wish we had a third condition in these studies, but that's where the ethical part comes in.
There's another question that someone posed that I think complicates Teo's series of questions even more. This is from Maddie Hino. A lot has been written about issues of mediation in settings where you have limited control. For example, real world psychosocial interventions.
Yeah.
For example, anything that affects both the mediators and antecedents of mediators will confound the results. Hence, randomization of mediators is suggested if one wants to draw conclusions of mediation. Is it even possible to do such randomization here? And they have a little reference for a famous piece on this topic.
For randomization of the mediators?
Randomization of the mediators and the antecedents of mediators.
Yeah, antecedents of mediators. Wish I had a really quick and good answer for that. It's an incredibly good question. I mean, what's running through my mind is, well, what might be an antecedent of a mediator in this population? I mean, I'm just trying to think as an example instead of abstract. And so, I mean, what's coming into my mind, but I'm not sure it's a good answer. But for example, there's more IPV than there is sexual trauma, for example. There's more current intimate partner violence. And we don't randomize based on current intimate partner violence. We assume the randomization, you know, we're not, I think, is that sort of, am I thinking about what maybe the question is trying to get at? Like one would specifically think, I think you'd want to consider in your own population, what might some of those factors be? Because I suppose you could randomize based on something reported in baseline assessment, I suppose, related to your mediator, but that would be quite a challenge to know exactly how someone scored and then have a whole randomization scheme from that. But I do wonder about things that might be most obvious. I mean, I think 35% of everybody that comes through the ART referrals from us have meet criteria, sexual trauma and symptoms. More meet for sexual trauma, but don't have symptoms. But it's probably close to double that for people that have intimate partner violence. You know, there's even more reported intimate partner. So I'm just using that as an example of what potentially could be related to the mediators, thinking of other things happening. And that's something we assess. It would just make the randomization complicated.
And that might end up being a discussion point that you and Talia discuss a little bit more if it's something Talia wants to weigh in as well. There's a question from Lauren Brown. This one is also about the content of the intervention. They say, I study trauma-informed HIV care. So obviously I'm delighted to hear from you today, exclamation point. My question is, when you think about studying trauma-informed care, in quotation marks, do you think it is critical to provide an intervention at the patient individual level, or do you think that you could provide an institutional level change alone and see change? I'm struggling with this currently.
Yeah, it's an excellent question. I mean, I alluded a little bit to trying to do the limitations of doing an individual level intervention in the context where we do, you know, where our participants live and where they get their care. Let's see, how do I say this? I think I'll just use a semi-data point. The number of women who say to us, nobody's ever asked me, I don't ever talk about this. I expect my providers, you know, this is just, no, we don't, this type of, I don't know if I want to use the word sensitivity, and not trying to, not, how do I say, in really busy clinics where people are queued up all day and there aren't mental health services and there's nobody to refer them to. This is just not something that's focused on in these settings. And so I do think there is potential, even the question would be, could could you train providers to be more sensitive and talk about this and build in these settings on the types of examples of really even building clinics around trauma-informed care in higher resource settings in a way that just that context could help them get to viral suppression. They may not get to it through mental health improvement. They may get to it through stigma reduction or reductions in shame. I mean, those are psychologically related variables, but it's not like a mental health treatment approach. So I think, you know, those types of sort of social influences and potentially structural factors could get to our endpoint of viral load suppression. I actually think that's possible in theory, if you could figure out how you could train. My hypothesis would be you could certainly train providers. It's whether you could change the setting enough to make that sustainable.
There's a related question from Anis Latifia. I'm sorry if I'm mispronouncing your name. Can behavioral interventions be combined with other interventions to increase the likelihood of successful behavior change? Sort of related to Lauren's question, but I wonder if there are additional aspects of intervention that could be included.
Yeah, I mean, yeah, I certainly think that, how would I say? A multi-component intervention would probably have the greatest likelihood of change, right? It's this challenge of, well, how many conditions do you have to have, or could you do it in a different kind of implementation design? Like, do we know enough from different effective interventions to put them together and not expect to have the same rigor of a fully experimental model, which then of course makes the mediation, that's partly why I made the comment about community level trials in the beginning, that I think trying to do mediation with so many potential influences makes that even harder.
Yeah. Now seems like a good time to transition to a discussion with Talia, Dr. Talia Cornelis. And for any of you who attended the second session, Talia was the person who led that session and facilitated it. She's a co-investigator at the Science of Behavior Change program, and she has offered to lead a discussion with Kathy about mechanisms in Kathy's research. So I'll pass it over to you, Talia.
Hi, thank you. Yeah, so I think that my primary task right now is to ask some very focused questions that relate to the SOBC experimental medicine approach. And just as sort of a quick overview reminder for people who were here last time or maybe who were not here, SOBC is really focused on understanding mechanisms that underlie behavior change. And so we really are trying to champion this approach to discovering why interventions do work or do not work, and believe very strongly that this will improve the efficacy, efficiency, scalability of our behavioral interventions. So I feel like I have a couple of questions that are very close to my heart that came up while you were talking. One, you sort of mentioned yourself. So one of the things that I've been thinking a lot about at SOBC is measurement and timing of measurement. And at the last slide, you alluded to considerations of timing for your full mediation test. And you talked a lot about measures of your viral load outcomes and things that are very sort of objective, right? Like a blood spot. But it's very different when you're measuring a mediator that's a self-report. So I was just wondering, when you're considering this like rigorous experimental design that you worked all the way up to, how did you take into consideration measurement and timing of these assessments?
Okay, thanks, Talia. Let's see. When we did the LIFT mediation model, which also had same number of time points. We basically did the growth curves in parallel. I mean, within the model, we assumed greater change from time 1 to time 2, and incorporated that because that's when the intensity of the intervention was. So in this case, there may be greater improvements in coping at 4 months. One could hypothesize differently in this trial, but that's what we hypothesized in that trial because they had matched interventions and no follow-up sessions in between. So we actually hope that the follow-ups in this situation strengthen the coping by having these brief maintenance sessions. So, and that should, we hope, improve adherence for very, very little intervention effort. So just to try to go back to what you were saying, I mean, our proposed plan is to look at the changes in coping through 8 months over those, those time points, with the primary look at does it mediate change at 12 months, so that they're not occurring at the exact same time, that they truly are like, where I am here, where does that, is that the mechanism that leads to the outcome later? So we think that's a slight improvement. And certainly I think even in the LIFT model, people often, at least at that time, weren't looking at the changes over time, like maybe look at where someone started at baseline as opposed to the changes over 4 or 5 assessment points. Those changes mediating the changes over time. So the growth model, I think, also adds to that. I had one other, so the points about measurement. I mean, coping is a good example. That's why I said, something about probably the most commonly used measure is the brief cope. But if you, most people use it, I have incorporated a lot of items from that. As it's written, it's 14 subscales, right? It's 2 items, 14 subscales. And so I remember having many a conversation about what's the best factor analysis to do for the brief cope. So you have subscales that are more than 2 items. And sometimes they fall together well and sometimes they don't. I mean, that's why you do a factor analysis on your own sample. So I think it's sort of like efficacy, like that's a situation specific, that, the best measures of self-efficacy are so situation specific that they're impossible to score as a collective. So, I mean, I think the moving towards the better measurement sometimes, it's the same push and pull in some ways, that the better you get for measurement, more challenging might be to get in your sample when it's so situation specific like this, like coping and self-efficacy and those types of things, which many of our interventions are based on, right? And that's what we did in this situation way back, because the other struggle we've had, in that's maybe a strong word, the other thing we've given a lot of thought to in this particular study is how specific should the stressor be? So therefore, should we tell everybody that how stressful that your response should be in response to how stressful HIV is? Is it how stressful trauma is? Like, how do you prime that question of how are you coping? Because everyone's situations are slightly different. So the way we got to this measure of coping actually was originally like the 90 item ways of coping that came from the Lazarus and Folkman model, which is the best measure, but nobody gives because it's 90 items. And then we looked at the brief cope, and we've used these measures over these 20 years and used them in South Africa and developed some of our own items based on formative work so that the cultural and language adaptation is more appropriate. So those are all things, not just the measure itself, but all things that go into a coping measure. I mean, we have had this very similar 4 or 5 subscale structure factor analysis that we've gone with in a few other studies. We also did a study in the early 2000s on coping with people over 50, thinking early on about HIV and aging, and that was a US study, but we did a lot of work on coping measures for that, so that we see these similar subscales across populations coming together, because we've basically made this coping scale a combination of standardized scales.
Yeah, that's so interesting to hear you talk about this, because measurement is such an important thing, right? And the first thing you said, it made me smile. You're like, this is the one that most people use. And that's true. That's actually often how we come to our scales. And then the second thing you said about the specificity of the situation and how that can be a challenge in terms of adaptation is also true. But we know, as like researchers who publish papers, who write grant applications, that using a standard measure can be such a push, right? And so it's almost easier not to try to make your measure correct for your situation because of the pushback you might face, because you're changing something that's established. And I actually also think it's funny because the brief cope is in the SOBC measures repository. So it could potentially have been useful for you, because you could have looked at, how that connects to the human behavior change theory and technique tool. But no, I think that's a great point. And some of the people who work with the Human Behavior Change Project group, like Mary Johnston or Diane Dixon, talk a lot about looking at scales within your specific sample, and not just an internal consistency reliability type analysis, but trying to really understand if it seems valid and if it's working within your own sample. And I think that's excellent that you've been doing that. So that was really wonderful to hear. All right, I have a couple more questions. So this one's probably easy or easier.
Don't say that.
You have this model, right? And in the past, you had an era where you drew from intervention to coping to post-traumatic stress symptoms.
Yeah.
And
yeah.
in this trial, you're using those two mediators separately. So instead of going from intervention to avoidant coping to stress to viral load suppression, you're looking at these two mediators separately. Could you explain the logic for that decision?
Yeah, it's a very good observation. And the logic, I would say, is because the outcomes are adherence and clinical outcome measures, it's possible from this intervention that one's coping could change, but the stress in and of itself may not change. In other words, reductions in avoidant coping or more active coping approaches without having it go like through traumatic stress could certainly lead to viral load suppression via adherence. I mean, and one reason I'd like to think that's true is that I would hope that if someone did a coping intervention specific to depression or to stigma or, something other than traumatic stress, that it still would have potential for impact on clinical outcomes. I mean, I obviously feel strongly about coping approaches to interventions, but I guess I would, that's quite a hesitant comment. That's how we think about it, that it could go either way, that it doesn't have to go coping through traumatic stress. And I think when I think back to deciding what to focus on for the LIFT model, in retrospect, I wish we would have come up with a way to see whether decreases in traumatic stress actually were a mediating variable for reducing substance use. Like we didn't do it we looked at it for a mental health outcome, not a behavioral risk outcome, but you could make the same hypotheses related to that. So does that help answer it all, or where you were thinking? That's
wonderful. I mean, again, part of what's so nice to talk to you about this is that when you present it theoretically and you just talk about like, this is the experimental medicine approach, it seems so neat. And then you take it to a real world context and you realize it's not that neat. There are things to consider that are in terms of measurement, in terms of design, in terms of ethics, in terms of practicality, and in terms of maybe there are multiple pathways and maybe we don't have to just follow this particular line that's been drawn by a theory. To that point, it's very interesting to me because obviously SOBC didn't even exist when you got started with all of this stuff, but you sort of followed our general approach anyways, which is you find your mechanism first and you're looking to see if you can change that mechanism, because a lot of your earlier work had coping and traumatic stress as your outcomes. And so with SOBC, it's you identify the mechanism, you intervene to see if you can change the mechanism, and then you see if changing the mechanism leads to behavior change. And that's exactly the trajectory you followed. And that sort of, I'd love to hear about how you think you came to that pathway. And then I have a follow-up question after that. Like what was going on in your space that led you to actually follow these steps just sort of naturally?
I think I'll respond and tell me if this is the direction you're thinking. How do I say? Sometimes you should just say brain to mouth. So that's what I'm going to do. What occurred to me first is that the bereavement intervention was really driven by my clinical experiences, right? That I had spent 10 years working with people that were dying and working in communities, and like what might have what might help, what might really work as in like what approach to take. So honestly, the first thoughts were clinically driven. And it was the opportunity to talk to Susan Folkman and what was her bereavement work and would a coping theory work, like that ability to like think through what might help improve the grief in such a currently traumatic grief situation. I mean, honestly, at the time it was very unique to have lost someone that you may have infected, that may have infected you. You may have lost a child. I mean, unfortunately, now we have the COVID experience to parallel that to the complicated nature of grief when those situations are similar. But that was really how I came to conceptualize the grief from my clinical experience. And therefore, I was looking for something that would theoretically ground a study design, an intervention to see if we could get people in a better situation in relation to the grief, people that were potentially dying themselves. I mean, all the complexities, right? So it was very initially clinically driven. Certainly, I guess between my I mean, I was probably a second year assistant professor at that point. I mean, I think I had the fortune to be mentored by people that were my dissertation mentor and Jeff Kelly. We were always very theoretically oriented in what we were trying to do. So in some ways, that's why I said it sort of lightly in the beginning. Well, of course you had a theory, but you really wanted a theory that was going to potentially work, not just say, oh, they tell you have to have a theory to get a grant. Like it was like, what might actually work? So that's how I would say I got to coping. And honestly, the reason I show the bereavement study slide is the fact that we compared a 12-session group intervention to essentially nothing. Like, okay, so it worked, but I mean, of course, it better have worked. I mean, goodness, if it didn't work, right? Because there was I mean, people had uptake of the individual treatment, but nothing in comparison to the others. So if I think back to the early thinking, it was, and I think that's one of the points I was trying to make, and how one sequentially changes their study design, because you learn something. I mean, sometimes I think it's good to have done this trail of mental health interventions that have something in common, you know, and the community trials were similar. It's like we did one, we learned, we focused on another population. What did we advance from it? So that's, I guess that's how I would say I came to it. I guess because if one goes to develop an intervention, you want to think about, well, what in it might work and what's my theoretical foundation for that. And then when you test the effects, I would think you'd want to know, well, is that why it worked? I mean, I remember thinking that in the gay bar study, we believe it worked because the social norms were changed and people had conversations. And Seth Kalishman, I think when we were running, he was doing the initial analyses, and we did what we called the bar. He came up with the barfly effect. It was sort of an intervention exposure question, but it was like, well, if you haven't come in the bar and sat here and had conversations, then it couldn't have worked anyway. We didn't think of it as mediating. We were just trying to understand why this might be working and what should be taken into account. I mean, in most in an behavioral intervention trial, you might just take dosage of interventions. In a community trial, we were trying to figure out what might represent whether you even received the intervention, right? So it wasn't mediating as much as trying to think about, was the intervention even received, first of all, and what was that? So I think I guess my perspective would be, as somebody that develops interventions, that's where your thinking comes from. So why would you not look back and figure out if that's what happened? Maybe we didn't want to, maybe we don't want to know if that's why it worked. like you asked, hey, well, what if it worked, but your mediators weren't the reason? But I also think it's a really good example of advancements in the field to say, like you're saying, you have this whole system of guiding and thinking and getting people to approach their intervention trials, assuming they're going to look for mediating mechanisms.
Yeah, I think some of the things you said again are great to hear, like this idea of we want to know why it works. And if your mechanism isn't the thing that changes, but it still seems to work, then it tells you something about your theory. And really distilling down the active components of your intervention, and that speaks again to the importance of a good control group, then you can really maximize your resources. You can really hone in on, okay, wow, this really seemed to change it. If we just boost up this dose of the intervention and this other thing didn't actually seem to do much at all. So like, let's zero in, let's intensify this component and try to do the most good that we
Well,
can.
and that's why the control condition in LIFT and the sexual trauma study in the States, we tried to account for everything else that might have been happening in the group contact, professional interventionists, like pretty much. And it wasn't like we said, you can't talk about sexual trauma in this group. It was a sexual trauma and HIV group. It just wasn't a coping skill development focus. And so we tried to set up the control to capture all the other things that could be improving for people.
Yeah, control groups are really important. I remember hearing a talk at some conference about meta-analysis and how hard it is, or almost impossible to draw conclusions in some of these meta-analyses because control groups differ so much. And so it's like these mechanism tests, distilling it down and really doing rigorous design to try to understand why something works is so critical. There was another thing that you mentioned that I thought was quite interesting, about the time it takes to get to this point. And it seemed to have taken a long time, a long sequence, a long buildup from focusing on the mechanisms to then the mediation to this hard, like viral load outcome. Yeah. And part of what we also talk about with SOBC is this focus on mechanisms, and transparency around mechanisms can help to speed up this process. So if everyone is measuring mechanisms and sort of collaborating in a systematic and very transparency is key, a transparent way. Let's say you measure 5 mechanisms in one study and none of them work. That's so important to know. Do you think that a sort of a broader focus on mechanisms and more transparency around mechanism tests could help to move us more quickly and from theory to intervention? Yeah. Something along those lines.
It's a very good point. What crossed my mind was, yes, I think transparency would help. I think the norm and expectation that that people are probably measuring these things anyway. Let's be sure there's some commonalities of measures used in a way that, like, if I show that, if I do a study and it shows that avoidant coping is the mediating causal factor, and Teo's doing something and he happens to have coping in but he didn't really focus on it. Like, how do people, maybe, how would I say this? And I don't know what people who are watching or what their experience is with this, but there's something about it that makes it sound like it's more complicated than one might feel they're capable of doing. But what I'm trying to say is, I think if the right study design and the measurement is there, one can do mediation analysis. Like, one may say, well, I don't know how. I could imagine someone saying, well, I don't have training in doing that kind of analysis. Or I'm trying to think of reasons that it hasn't become more normative. And I actually just think it's encouragement to focus on them, not that people aren't necessarily measuring. They just don't necessarily go back and look. That's why I also started with the bereavement study to say, had a couple of great postdocs who were like, well, let's go back and look, right? Like, it wasn't a matter of, this was a part of what was stated from the beginning that we were going to do. And so if I wouldn't have stated this in my abstract because I wanted to do it, I would have all the same data points anyway. I think that's just one practical thing. I would have set this study design up, honestly, the same, even if I hadn't hypothesized a mediating mechanism, but that's because of the sequence of studies and what I wanted to know. I think as more people realize that there are ways to do this, there are resources to do this, and to think about that, it would become more normative, and there would be more transparency and sharing of those things.
Yeah, one thing that's true is that we think in these causal pathways. We're not just like, I'm going to give you a group therapy session and now you're going to have suppressed viral load. We don't just say that, right? We say, well, I think it's going to work because. Yeah. But there's a disconnect between causal thinking in us as individuals and the way that we implement it in our study design and analysis. And I think some of that's just disciplinary differences in terms of focusing on different types of design or training. And I also think it just hasn't been emphasized to the same degree, which makes sense, right? So it's like, we want this to work. Does this work? And now it's more this focus, and you can see this not only with SOBC, the Human Behavior Change Project, other initiatives as well, are really saying, well, it's not enough to know that something works because it doesn't work all the time and we don't know why, and it works better here and not so well here. And understanding the why can really help us to achieve our ultimate goals of changing these hard, like, behavioral health outcomes.
I mean, it makes me think of, I remember discussions very early on in like the behavioral prevention work where we would all, after something would be shown to work in like skills training or behavioral prevention, and we would think, we'd sit as investigators and talk about what we thought it was in the intervention that was key. It's like we were asked to identify key elements. It's kind of a backwards way of saying, what do we think was most important in the intervention now that it's over, as it got put in for a particular reason. And I remember, like, skill development, it's essential that people have role plays and you practice, all the behavioral aspects. And then when you would take that to like the next step for dissemination and implementation, you would find that people were never comfortable doing role plays. And therefore they were just excluding them from the interventions. I mean, it's a very practical, that's more of a content thing, but it's a similar idea, which is the more we know about what it is in that, I've always said, what's in the black box? Like, what's in the box? After the gay bar study was, this will really date me. I mean, the CDC would put that as a, oh gosh, what were they called? They were like intervention packages, and they'd literally be in a box, like a rectangular box, and you'd open it up and there were all your manuals and your videos and all of that. I know nobody does this anymore, but I always use that as an example of, you have an intervention in a box and all we know is that that intervention is in a box, and we don't necessarily know what change it made or what elements are the most important. And so I think that all ties to this question. And I think I would say, certainly for myself, that I always thought about these things, but we often just then moved on to the next project. I mean, just to be practical about the way, the reality of research. And so that's why I think the transparency and a norm change to thinking about this from the outset can do, it could have so many positive impacts, like advancing the field in theory and all of those things, but also tells us in implementation what's the most important thing to be sure we're implementing.
Yeah, I think I have time for one more question. So sort of piggybacking on what you just said, theory. We talk about how we should do mechanism tests, and there are so many things that you could do, so many combinations, so many different pathways, so many different theories. Mm-hmm. And we use those to inform our study designs, but how do you choose? And I know you talked a little bit about how you chose your theory, but I also then wonder, do you feel like your theoretical framework has ever constrained you because you feel like you're stuck in this coping theory? Or conversely, do you feel like some of the work that you do is trans-theoretical, like you're looking at components from these different theories? And when you're doing this research and finding evidence for causal pathways, or evidence in support of causal pathways, do you see this as supporting one theory, or do you see it as supporting like this sort of trans-theoretical soup broadly?
It's a very good question. I certainly think of myself as trans-theoretical. I think that I really focus on the coping part because it's the foundation and it's the piece that goes throughout the intervention. There, I think the whole like we have components of motivational interviewing in the beginning where people set their values and why do I want to take meds? What matters to me? Like there are components of other theories that make it multi-component in a way that flows together. And I definitely think that in more behavioral trials that I have done. I mean, I will say, one of them with like newly diagnosed men was, we went with IMB because it was a brief intervention and it seemed simpler, and that doesn't mean that IMB can't be longer, but we tried to think about what could you do in 2 or 3 sessions and what was a theoretical foundation. So sometimes I imagine the population and the anticipated intervention drive that to a certain degree. So I mean, I guess I look pretty wedded to coping because that's what I was showing you over a few interventions, and we did a few of them. But I actually think that there are more components to it than that, which is why I at least try to note the other evidence-based treatments that are integrated.
Yeah, this is just wonderful. I just want to say I loved your talk. It's so nice to see that the things that we talk about as important at SOBC are being done. And it's nice to think that disseminating this method can help to promote like a focus on this more intentionally, and promote better intervention development, and I think more transparency, rigor, and collaboration. So thank you so much for all of your work.
Pleasure. Thank you.
Thanks for having that discussion and letting us witness this very stimulating conversation between the two of you. Talia, you really summed up the purpose of this seminar series in a nutshell, so I don't need to say more about that. There was a really large response to this series. So many people registered. We had originally designed this to be more a smaller group of people having a little bit of a seminar. So with that in mind, we have scheduled something for January 31st, which will also be 90 minutes, but it'll be a little bit more hands-on. It'll be like the second session in which Talia did a sort of masterclass with me on how to work on mechanisms in my research, but those who attend will have more of an opportunity to actually experience some of that guidance from Talia and from Jeffrey. So we'll send that announcement via email in the coming weeks. It'll be first come, first serve. And we hope if it's successful that then we have future collaborations and seminars down the road. Kathy, thank you so much for sharing your work with us and allowing yourself to be under the microscope of the SOBC program and a method so that Talia can discuss this with you. It was really terrific. Thank you so much. I hope everyone has a great day, and we'll be in touch down the road.
Thanks, everyone.
Take care, everyone.